Sir, you can start, sir. We are on live now.
Good evening, everyone. And on behalf of Endocrine Society of India, myself, Dr. Sandeep Kumar, welcome you all to this chapter of ESI case capsule, which is one of the most awaited endocrine academic events of the country. And today we are very fortunate that we are having a Dr. Alpesh Goel, the Associate Professor from Department of Endocrinology, All India Institute of Medical Sciences, Bhopal, who had kindly consented to be a faculty moderator for today's case capsule discussion. And sir needs no introduction, and he is one of the finest and excellent teacher and a doctor, and his humble personality and ever, he's always available is one of the most important things which make him a faculty of, class apart. And I myself has drawn a lot of inspiration and learning from him whenever I've interacted with him. And thank you, sir, for consenting to be a moderator for today's case capsule. And today the case will be presented by Dr. Sharad Chandran, who is the senior resident in Department of Endocrinology at SMSJ. We have Dr. Archana Rao from KM Hospital, and we have Dr. Ranita from Kolkata. And with this, sir, without wasting much time, I'll hand over directly to you, because today probably Dr. Kaushik Pandit and Dr. Sambit could not join because of their commitments. Over to you, sir. Thank you.
Thank you so much, Dr. Sandeep. Good evening, everyone. It's a privilege to be part of this activity, and I would want to put on record appreciation for Endocrine Society of India for taking this initiative that is helping so many students, and greatly thankful for allowing me and my department to present this learning case. So I'll invite Dr. Sharath, who is a senior resident in our department, first year DM resident, to present the case. Dr. Sharath, it's yours now.
Thank you, sir.
Yeah, you can start.
Nice. I hope the slides are visible and I'm audible.
Yeah. Slides are visible. You are well audible.
Okay, thanks. Good evening, respected teachers and my dear colleagues. Today we'll be presenting a case on atypical thyroid function test, a familial conundrum. Going on to the case, history part. Say, 49-year-old female who presented to us for evaluation of a thyroid problem that remained unsolved for past few years. The initial presentation was in August 2013. That was when she was at the age of 37 years. When she presented with the symptoms, with vague symptoms such as weight gain and behavioral problem at an outside hospital. Her initial thyroid function test revealed an high thyroid hormone with a T4 of 17.1 microgram per deciliter with an unsuppressed TSH of 4.53 micro-IU per ml and T3 of 186 nanogram per deciliter. At this point, no specific treatment was initiated. In the next few years, for the next 7 years, she went on annual testing of TSH, and values were ranging from 2.4 to 9.7 micro-IU per ml. And in Jan 2020, considering a elevated TSH from an outside hospital, she was started on levothyroxine replacement. And her abnormalities in thyroid function test persisted even after that. Her TSH and thyroid hormone levels persisted in the higher range despite being adequately compliant to a levothyroxine supplementation of 100 microgram per day. Coming to the thyroid function test as such, this was the index thyroid function test where TSH was 4.5 with a T4 of 17.1, which was almost 1.5 times the upper limit, and a T3 of 186 nanogram per deciliter. And this was the follow-up TSH values, and it was at the TSH of 8.6 she was started on levothyroxine. In follow-up thyroid function also, we can see that despite being adequately adherent to the medication and on a replacement dose of 100 microgram per day, her T4 was 17.7 with a TSH of 3.7, and follow-up it was like 6.9 to 10.47 in 2022 with a corresponding T4 of 17.3 to 90.
Okay, we can
and in
on the previous slide, we can stop and have a discussion.
Sir,
You can go back to the previous slide.
yes.
Yeah. So I think in this case scenario, we are seeing that there is elevated thyroid hormones with a normal TSH initially, which has begun to rise from January 2020. and then patient has been started on treatment, and still, despite good compliance, we find that it is difficult to control her TSH. So I will begin with student panel. Dr. Isha, maybe what is glaring abnormality in the thyroid function test? Maybe the index thyroid function test. We know that in thyroid problems, it is the index thyroid function test which makes all the difference. So based on the index thyroid function test, what glaring abnormality do we see?
So only like according to this, the T4 and T3 are elevated. T4 is around 1.5 times elevated, but the
Yeah.
TSH is in the normal range. So that
Okay.
could be because of an increase in thyroglobulin levels. Sorry, not thyroid, TBG levels, the thyroxine binding globulin levels.
Okay.
Sorry.
Okay. So
So secondly, it could be due to some assay interference.
yes, very good. Okay, so let's just discuss the first differential. So
Yes.
first differential you have kept is thyroid binding globulin issue.
Yeah,
So
TBGs.
how do you kind of circumvent then on history, and what additional tests do you need?
So on history, we'll see whether the patient is like having, whether the patient is sick during the time of sickness, or he is on any supplements like estrogen supplements. That will
So
lead to increase in TBG.
right. So we have to know whether patient is taking
Is
any
any
estrogen or estrogen
yes.
containing preparations. Generally, in sickness or acute illness, you expect
Sorry, the decrease. Sorry, the
yeah.
TBG will
So you
decrease.
don't
Sorry, my
expect
bad. Yeah.
high. Yeah. So that's correct. And you would also want to measure free
Free
hormones.
T4, yeah, free T4 and free
Yes.
T3 levels.
So we keep this in mind that we will have to look at free hormones at some point in time in order to ascertain that whether this is a binding globulin issue.
Yes,
And
sir.
what is this pattern of TFT commonly called as, where T3, T4 are not concordant with TSH? So this is the title of the topic. This is atypical thyroid function test. This is also called as a weird thyroid function test. Some people label it as discrepant thyroid function test or a funny thyroid function test, where T3 and T4, they are not concordant with TSH. You expect that with high levels of T3 and T4, or I must say free hormones, you expect a suppressed TSH. So that's one definition of atypical thyroid function test. Or another definition is when you have a TFT that doesn't match the clinical context. For example, you are getting a picture of thyrotoxicosis, a biochemical picture of thyrotoxicosis in a patient who is clinically euthyroid and is consuming biotin. Or there is a heterophile antibody interference causing high TSH in a patient who is absolutely normal. So this is what we call as atypical or weird thyroid function test. So I think we have discussed here that there is some issue with the TFTs, and we would want to get additional investigations, which we have already discussed, that we want to get free hormones at some point in time, and also whether patient is taking any OC pills. Okay, Sharad.
And further follow-up, in 2022, she was advised to stop all the treatment. Her thyroxine was stopped, and a thyroid function test was repeated 8 weeks, which revealed a severely elevated TSH of 91.8 micro-IU per ml with a mid-normal free T4 of 1.37 nanogram per deciliter and a high normal free T3. And at this point, she was asked to resume the levothyroxine supplementation, but the abnormal thyroid function test still persisted. Here we can see this was the thyroid function test after stopping the thyroxine for 6 weeks duration, where TSH went up to 91.82 with a mid-normal free T4 of 1.37 and a high normal value of free T3 of 4.27. And in follow-up also, she was restarted on thyroxine with adequate compliance to the medication, but her TSH remained in the range of 5.5, 5.4 with the T4 fraction ranging around 17.4 and a free T4 corresponding to 2.35, which was the abnormality was persisting. And so,
we can go back to the previous slide. Okay. So, again, I think the question about raised free thyroid hormones is now clear in 2023 FAB TFT, which shows that even free hormones are elevated in face of a normal or elevated TSH. So, Dr. Archana, what is the abnormality in the TFT dated 2022 September, and how does that help you further?
Stopping the LT4 supplementation, wherein there's a very disproportionate increase in the TSH level, and the T4 for the T3 for the first time is also elevated, borderline, with T4 in the normal range. So,
Okay.
before this, the pattern we were seeing is that T4 was raised with TSH also elevated. This time T3 is raised. So since all three are on the higher range, we can think of RTH beta here, and perhaps even RTH alpha if facing FP3 is more raised. But later on in 2023, since both are uniformly raised with the TSH also being raised, we can think of RTH beta or TSH or not, which is a pretty long-standing history, but that's still a differential to consider.
So I think you have a correct assessment that if you see 2023 February TFT and compare it with September 22 TFT, we see that free T4 when it is declining from 2.35 to 1.37, there is an increase in TSH. So there is a normal HPT axis function, but possibly the axis is set up at higher free T4 levels, right? That is what we are seeing. So at a TSH of 91.8, considering the inverse log linear relationship, we would have expected an absolutely low free T4 levels, but that's not happening here. Free T4 is well in the mid-normal range, and in fact, free T3 is in the high normal range. So this becomes very suspicious for a resistance, especially at the pituitary level, which is causing high thyroid hormones for a normal TSH, or we can say that at any level of TSH, there is more T4 production, right? So any other point that we see, she's on 750 micrograms of levothyroxine per week, which is around 107 micrograms per day of levothyroxine. And we are seeing that her TSH has hovered between 6 to 10 during her follow-up visits. So does that also help us?
I think the fact that there's a response TSH is actually suppressed with supraphysiological doses of LT4.
Her weight is 58 kgs.
Okay, so around, okay,
So she's receiving around 2 micrograms per kg,
okay.
which is well in the range that we expect for a athyroidic patient to respond. But we feel that she does seem to have treatment-resistant hypothyroidism also, provided everything is okay, compliance issues, technique issues that we have inquired, they are okay. She's not taking any PPI. There are no other malabsorption issues. So that is another thing that we are keeping in our mind, that there is difficulty in normalizing her TSH through exogenous supplementation, and she seems to have a defect at the level of pituitary. So with this in mind, we can move forward, Sharath.
Coming to the rest of the history part, past history, she is a non-case of systemic hypertension for the past 3 years duration and was on well controlled with a cilnidipine 10 mg per day and telmisartan of 40 mg per day. Menstrual cycles were regular. Obstetric history, there is a history of miscarriage in first pregnancy, which was at a period of gestation of 2 months. And second delivery, she delivered a female child who is at present 20 years of age. Family history, she's the youngest of 7 siblings. One of the elder sister is being treated for hypothyroidism.
On the previous slide, yes. So why have you put hypothyroidism in inverted quotes here?
Because one possibility is that in conditions like, especially in conditions like RTH beta or in other TBGXS or dysarthria or family histories, very important, and the family members can have a similar pattern, which is important, which may be mistreated in view of a confusing thyroid functions.
Okay. We shall discuss later, but it is something that we will keep in mind as we move forward in the case discussion. So please go ahead.
Coming to the negative history, there is no history suggestive of any hyperthyroidism symptoms or any history suggestive of orbitopathy or dermopathy, no history suggestive of any hypothyroidism. There is no history of any OCP intakes, no history of suggestive of any autoimmune disorders in the past. Examination wise, her vitals were stable. BMI was 24.9 with a weight of 58.9 kg. Neck examination revealed soft grade 1 goiter with no palpable nodules. no tremors and no eye signs, and rest of the system examination was unremarkable. Coming to the investigation part, the rest of the investigation, including a complete blood count, blood glucose, HbA1c, renal function test, and liver function test, and a calcium profile was normal. Coming to the case summary so far from history and examination, it's a 49-year-old female with a background history of systemic hypertension for past 3 years duration, well controlled on medication. Now presented with an altered thyroid function test, which has been persisting for over past 10 years. Initial thyroid function test showed a high thyroid hormone with an inappropriately normal TSH. And later over the years, this has evolved to an elevated TSH with an inappropriately normal to high normal thyroid hormone, along with a difficult to normalize TSH despite adequate supplementation. And examination was normal except for a grade 1 goit. The differentials.
Here, and let's invite differentials. You can project this slide, and let's look at the differentials. First, let's look at the differentials for the biochemical profile that she had presented with at the index presentation. Suppose you were seeing the patient in 2013 August when she presented with elevated total T4 and elevated total T3 with a normal TSH. What would your differentials have been? You can just enumerate. So I can begin with Dr. Anita.
Sir?
Yeah.
So for raised T4 and T3, my one differential will be that patient will be on any OC pills or not.
Okay, so that's acquired TBG excess.
Acquired
That's
TBG
one
excess.
that you can keep.
Yes, sir. Second one is RTH beta, I can keep off.
Yes, good.
And TSH is normal, right, sir? So TSH secreting pituitary adenoma, TSH-OMA, I can't keep. So I will keep these two things: acquired increase in TBG and RTH beta, right?
Okay. Okay. So she has listed out two differentials. Dr. Isha, going back to you, do you agree that TSH-OMA will have elevated TSH at all times?
No, sir. It can have normal TSH as well.
So it can have normal TSH unless there is a history of
TSH-OMA could
unless
also
there
be
is
a differential. So.
yeah, unless there is a history of previous radioiodine ablation or
Yes, sir.
thyroidectomy, which they inadvertently they have been subjected to. Okay, so RTH beta can TSH-OMA can still be a
Be
differential.
differential. Yes.
Any other you would like to add?
So assay interference with
Assay interference.
yeah.
So what kind of assay interference? What kind of antibodies, or what is the interference that you are expecting?
So mostly with biotin interference, which is commonly present in over-the-counter supplements, but that will lead to a suppressed TSH with increased T4. But still, I think we can keep one differential.
Yeah, fair enough. That can be kept. Biotin
Sir,
interference, but you have to look whether the assay is using biotin-related
Biotin.
monoclonal antibodies. Yeah.
Yes.
Okay.
And so
That's
another one, we can put the drugs which can displace the thyroid hormones from the binding proteins, like any interference from heparin or fusimide or phenytoin.
okay. Okay. Good. Drug interference. Any others? So Dr. Archana, would you like to add?
So we can also think of, I mean, I think she said head profile antibodies already for both against the T4, T3 and the TSH, but because of so many repeats, maybe that will be lower down. Familial with this albuminemic hyperthyroxemia, maybe.
Okay, that's one we can keep. We can keep that. Okay.
So
And,
can we keep amiodarone as well in the drug?
Amiodarone, yes. We'll discuss all of that. That's correct differential that can present with elevated thyroid hormones with normal TSH, especially elevated T4. Okay.
even transthyretinemic hyperthyroxemia can be a differential, but that would be again more likely in a male because it's extinct.
Yeah. Okay.
And then the other thing to consider would be if someone is non-compliant to therapy, I mean, but over such a long period, probably not.
So, okay, non-compliant to therapy, but the TFT pattern that we saw was preceding the diagnosis of hypothyroidism. So,
Right.
that becomes less likely.
Okay.
Membrane transport defect or metabolism defects, could they also have similar presentation? They come under the broad spectrum of impaired sensitivity to thyroid hormones. So,
Yes.
along with RTH beta. And although this is not the case in this patient, even acute non-thyroidal illnesses can have elevated total thyroid hormone levels, total T4 or free T4 with normal TSH and a low normal T3. So I think we will discuss each differential as we go through. Sharath, you can move to the next slide.
So these were the differentials that we have to consider when there is a high thyroid hormone with an unsuppressed TSH. As already mentioned, TBG excess is one possibility where you get an increased T4 and a normal TSH with a normal free T4 if done with a especially if done with a standard measure like equilibrium dialysis. TBG excess is usually resulting from an X-linked disorder due to a gene duplication or triplication. Patients typically will be clinically euthyroid. Free thyroid hormone concentration will be normal. Next differential that we have to consider is a acute non-thyroidal illness, which can have any pattern, typically with a low T3, can have an elevated T4 with a normal TSH. But in our clinical scenario, this was far out of the picture because of the overall clinical presentation and duration. Next is a familial dysalbuminemic hyperthyroxanemia, where you can get a elevated T4 and elevated T3 has also been described as familial dysalbuminemic hyperthyroxanemia has been explained, and free T4 which can be elevated or normal, especially to be kept in mind that it can be elevated if the assay that we usually use mostly is an immunometric assay. In immunometric assay, it can be for the free T4 can be falsely elevated because of the tracer getting bound to the the mutated albumin can bind to the tracers as well, resulting in a high estimation of free T4. Usually, familial dysalbuminemic hyperthyroxanemia has a autosomal dominant inheritance and up to two-fold elevation of total T4 with minimal changes in the total T3 is the usual pattern that we see. The next two differential, one is resistant thyroid hormone beta as well as TSHOMA, as we have already discussed. They can present with an increased T4, increased free T4, increased T3 with normal or high normal or slightly elevated increase in TSH is the usual pattern. We'll come to these two differentials in detail in coming slides. The other differentials with the given biochemical profile with the given thyroid function, one possibility is a MCT8 mutation and second possibility is SBP2 mutation, even though these are not typical to the clinical presentation that we have presented, because these are usually the presentation is in the pediatric age group. The MCT8 mutation usually that is a thyroid hormone cell membrane transporter defect, which is X-linked recessive, that is male will be affected, female will be carriers with 100% penetrance, and usually presentation is in the infancy or in the early childhood. They can have present with cognitive defect, feeding difficulties, hypotonia, later progressing to spastic quadriplegia. And next differential is SBP2 mutation typically has a low T3 with an elevated T4 and elevated free T4 with normal to increased TSH. This again usually presentation is within the childhood itself with delayed growth, failure to thrive and developmental delay. It is a thyroid hormone metabolism defect, which is due to selenocysteine insertion sequence binding protein 2 gene mutation, which is on chromosome 9. Inheritance is autosomal recessive. The affect the synthesis of selenocysteine, which is actually an essential component of the deiodinase enzymes. That is part of the thyroid hormone intracellular metabolism. The other differential, as we have already discussed, autoantibodies interference is an important differential when such a profile comes up. And last one is T4 therapy, that is, as previously discussed, a poor compliance resulting in increased TSH and a recent dose resulting in an increased T4 and free T4. But this was also unlikely in our picture, in our case, as it was pre-existing problem with the thyroid function test.
I think one of the most important aspects, please go back to the previous slide, is about the autoantibodies and the assay interference, because that's something that I would want to bring home. So what kind of antibodies are we talking about? So Dr. Archana, what kind of antibodies can interfere and cause high thyroid hormone levels?
Yes, so there's the autoimmune, which is either against TP, T4, and TSH, or the anti-reagent antibodies, which is generally routine name that's used, that used to be used at the assays. So they can be either specific and with high affinity, or they can be polyvalent and heterophile, which
Okay.
we generally
So
get.
please stop there. So basically, we want to discuss auto T4 or auto T3 antibodies, which can give rise to increased T3 and T4 levels in this patient. So are
Right.
there any particular assay platforms which are more susceptible to this effect, or it is universal?
Right. I think I'm not sure if Roche and Abbott, I'm not sure if I'm mixing them up.
Okay. So I think
Radio immunoassays will have, I think, false positive.
radio immunoassay is a general terminology. So
Okay.
there can be basically it is more seen with one-step immunoassays rather than two-step
Right.
immunoassays. So what happens with one-step immunoassay is that it's a competitive binding immunoassay for thyroid hormones, T3 and T4. They are small molecules. So we have T4 or T3 which is present in blood, which is competing with labeled T4 or labeled analog for limited number of antibody binding sites. If all three are incubated in one step, then what can happen is that if there is excessive amount of autoantibody that can not only bind to T4 in the blood, but it can also bind to the labeled T4. So what it will do is it will remove labeled T4. And we know that if labeled T4 is removed without binding to the solid phase antibody, what will happen? It will lead to loss of signal. And the loss of signal in a competitive assay will lead to increased or falsely increased thyroid hormone levels. But if you have a two-step immunoassay platform, such as is seen in Abbott Architect platforms, what will happen? That initially endogenous thyroid hormone is allowed to interact with the solid phase antibody. And then there is a washing step. So in the washing step, all the autoantibodies will be washed off. And then you will introduce the labeled analog. And in the labeled analog, that will have independent interaction with the thyroid hormone binding antibodies, and there will be competition. So there will be no effect of the autoantibodies. So this defect is mainly peculiar to one-step immunoassays, one-step labeled analog immunoassays. So it's a good practice to change the platform, and not only to change the platform, but to know how the platform is, what the mechanism of thyroid hormone estimation in the platform is. Similarly, Dr. Sharath told us that in albumin gene mutations, which is seen in FDH, you can get free thyroid hormone levels with the one-step assays, but generally not with the two-step assays. The concept is again similar. Here the abnormal albumin binding is leading to sequestration of labeled analog. Just like autoantibodies were sequestering the labeled analog, this time the abnormal albumin is sequestering the labeled analog, and this leads to a high thyroid hormone concentration in the one-step immunoassays. So if you have the two-step, you will have washing and the albumin will be washed away. So that's one that we should always remember, that good to change platforms and to also know what platform we are, what's the mechanism. I think rest of them we have discussed. MCT8 will be an X-linked, so unlikely to present in a female with such severe biochemical picture. SBP2, somebody would like to illustrate what is selenocysteine and what is its role in thyroid hormone metabolism? Dr. Sharath, you would like to take this?
Selenocysteine is actually defined as the 21st amino acid, which is actually has some peculiarities, that it is actually cysteine with its sulfur center being removed and replaced by selenine, which is the only amino acid that has an micronutrient, essential micronutrient in its basic structure. And it is the essential component of deiodinase enzymes, which is important for the metabolism of thyroid hormones. The selenocysteine forms the integral part of deiodinase enzymes.
Yeah.
So it's actually a metabolism defect that is resulting from its mutation.
Yeah. So selenocysteine, you rightly said it is 21st amino acid. The important point is that the codon that codes for selenocysteine is UGA, which is a stop codon. So in order for that stop codon to incorporate selenocysteine, you require a selenocysteine insertion sequence. And so selenocysteine insertion sequence binding protein defect leads to deficiency of many selenoproteins, one of which is deiodinase. So this is not a transcription defect, it's a translation defect. So in fact, studies have shown that the deiodinase enzyme levels are low, but the deiodinase mRNA levels are normal. So that means that there is defect at the level of translation because the SBP2 protein is defective. So I think we can move forward.
So from the given discussion, it's clear that the differentials that were considered and from the clinical scenario, 3 differentials were strongly considered. One is resistance to thyroid hormone beta, second is a TSH-OMA, third is an assay interference due to antibodies. On top of all this, there is a thyroid insufficiency that is developing, that is a primary hypothyroidism that is developing in background of any of the above. Since the TSH went up to 91, that is very well above the normal limit. It was indicating that there is a primary thyroid insufficiency that is evolving along with this. So the first procedure was to take over the assay interference issues. So we repeated the thyroid function test in 2 different platforms. This was while the patient was on thyroxine, where we can see that the profile remained the same. That was T4 was in high normal or just above normal range with the T4.9 and 4.4 in different, with the T4 of 17.3, which was again very well elevated. And in the next platform also it was 18, which was also very well elevated. So similar pattern, and in free T4 also similar pattern was seen. So the pattern was consistent over 2 different platforms. And on further evaluation, we had stopped the levothyroxine for 4 weeks and assessed also, which was in Abbott assay, where we could see that on stopping the levothyroxine, TSH went from 4.94 to 12.01, with the T4 of still in the upper range after 4 weeks of stopping, that is 17.3, it came down only to 15.2, that is still elevated, and a free T4, which is again above the normal limit of 1.56, and a high normal T3 was at the end of 4 weeks of stoppage of medications. So once the assay interference was taken care of, the main 2 differentials that were left behind, one is resistance to thyroid hormone, second is TSH-OMA. So this
Previous slide. Okay. One thing I just wanted to make clear that the Abbott Architect platform is a 2-step immunoassay platform. So that is why we chose for a Abbott Architect platform, and that's an in-house platform that we have actually. So now we can have 2 differentials. I think all of us agree that the 2 major differentials that are left are RTH beta and TSH-OMA, and let's tease out the diagnosis between these 2. So Dr. Anita, just tell us some differentiating points between the 2 etiologies. Dr. Anita. Okay, Dr. Isha, you can pitch in.
So mainly the in TSH-OMA, the feedback regulation would be disrupted. So there would be no response to TRH stimulation, while in RTH beta mutation that would be sir, we'll see a response to the TRH stimulation. The TSH will increase, so that feedback is preserved. And
Okay, so
even in TSH-OMA, there will be no suppression on giving exogenous T3, on giving exogenous T3, same due to the loss of feedback mechanism. We can see a tumor maybe on the MRI screening in TSH-OMA, while that is a genetic mutation.
okay. Any other points, Dr. Archana, you would like to add?
So the alpha subunit of TSH is raised in TSH-OMAs.
Yes.
And also it might be SRL responsive as an after
Yes.
3 to 4 months of therapy. And in RTH beta here, this case, she has a sibling who's also has similar outcome history. So maybe we can think about RTH beta if her TFE is similar.
Any role of biomarker of thyroid hormone action?
SHPG? The SHPG levels are elevated in TSH-OMA, whereas because of the resistance of at the level of the liver here, there will not be elevated levels of SHPG. And besides that,
I think that's good enough. We can, Sharath, we can move and discuss few points.
So coming to differentiating between RTH and TSH-OMA, one of the important differences from the history is that Clinical thyrotoxicosis is usually seen in TSHoma and usually absent in case of RTH. But even in TSHoma, it will not be frank thyrotoxicosis symptoms may be absent. Second is a family history, which is present in up to 75 to 80% of resistant thyroid hormone and is usually absent in TSHoma. Third will be an alpha subunit to TSH molar ratio, which has been said to be elevated in up to 80% of the TSHoma, where thyrotropin, there is alpha subunit production along with TSH. So the molar ratio remains elevated, but availability of this is an issue in our scenario. Fourth point is we can look for a pituitary MRI, we can look for an adenoma. For usually TSHoma, up to 70% they have macroadenoma and 30% will be microadenoma. But it is to be kept in mind that in an adult incidentalloma is an equal possibility, that RTH with incidentalloma is an equal possibility. Second, the next point will be to assess the other pituitary hormone, because the common pituitary lineage can result in an hypersecretion of growth hormone as well as prolactin in case of TSHomas. Up to 30% of TSHoma can co-secrete growth hormone or prolactin. SHBG is, as already mentioned, is a peripheral marker or a biochemical marker of thyroid hormone excess action. It can be elevated in a source of hyperthyroidism. So that in all cases of a thyrotoxicosis, but it can be normal in up to 70% of TSHoma is said to have an elevated SHBG. It can be normal in resistant thyroid hormone because it is a beta-mediated action that results in SHBG production. TRH stimulation usually results in an exaggerated TSH increase in RTH, and due to the autonomous production of TSHoma, it usually does not respond to TRH or to a T3 suppression where the feedback inhibition is also lost. But it's usually TSH will, even though there is a blended response, there will be a suppressive, it will be suppressible in, it will show some sort of suppression in case of resistant thyroid hormone beta at high dose supplementation. Octreotide suppression is another modality of differential where the TSHoma will show response. And finally, germline TR beta mutation can be elicited up to 75% of RTH beta cases can have a elicited germline TR beta mutation. So this is just a rough this is a flowchart to describe how to differentiate between an RTH. Most of the points are that we discussed only. Once the assay interference, everything is rolled out, to do a first is to do a family screening. As we already mentioned, family screening will be highly likely positive in case of resistant thyroid hormone beta. Next is a pituitary MRI to look for adenoma. We can do a serum SHBG, or if available, we can go for alpha GSC with TSH molar ratio. Can go for a TRH test again if available, if it is available at our place. And next will be a T3 suppression test, which will show a partial response in case of RTH and will be negative in TSHoma. And somatostatin analog is one test that can be used to diagnose TSHomas. And finally, we can go for a genetic analysis. So in our case, we went on this one by one. First one was to get a thorough familial screening. Here we can see this is the index patient that is marked as 9, and on family screening, one of her sibling elder sister was found to have a similar pattern. We'll show the thyroid function test in the next slide. And her daughter was also showing similar pattern, similar thyroid function test pattern. And the people who are marked with the daughter, we couldn't get them for screening, and the rest were negative for screening. So this is the thyroid function test evaluation. You can see this was the index patient, and number 5 was her elder sister who was on supplementation of levothyroxine, who showed a similar pattern with a TSH of 6.65, being on thyroxine of 100 mcg with fair adherence, and a T4 of 15.7 and T3 of 2.13 nanogram per ml. And the index patient's daughter, which was marked as number 11, you can see that TSH was 3.08 with the T4 of 16.6 and T3 of 1.84, very similar picture to what the index TFT of the initial patient was. And clinical evaluation of the daughter showed she had complaints of agitation for past few years. She's currently 20 years of age. Examination was within normal limit. Pulse rate was 100 per minute, but was regular. Grade 1 soft goiter. Other examination was unremarkable.
on, just a technical question. What can explain palpitations in her daughter? Any one of the what can explain palpitations in the daughter of the proband?
Alpha receptors are present in the cardiac around the heart, so that leads in, and there's a high level of TPO already, so that would result in tachycardia and palpitations as the symptoms.
And the absence of palpitations in the mother.
Right.
So
Mostly they're eumetabolic. Very rarely, the smaller percentage of them will be hyper metabolic. The sensitivity varies.
So yes, you are correct that there can be a lot of heterogeneity even within the family members. So some of them can have some manifestation, others could have, depending on the degree of tissue sensitivity to the thyroid hormone and the degree of compensation. So it's not that there will be a good genotype-phenotype correlation. So there will be a lot of heterogeneity. And what explains the goiter in both the cases that we have seen, despite there being normal TSH?
Chronic stimulation of the, there's always a chronic TSH elevation. I think something about sialation.
TSH is not elevated actually. TSH is normal actually in the daughter, at least TSH is normal, and the proband also, it was normal for a good period of time. Dr. Sharath, would you like to explain what's causing high thyroid hormone levels and actually a goiter? There is no TRAB, there is no HCG, there is no other molecule that is stimulating thyroid hormone. It has to be TSH only, because there are studies which show that the TRABs are not elevated in these patients. So it's actually the TSH which is immunoactive, but it is more bioactive as compared to the TSH which is found in controls. And the same goes on for TSHomas also, who around 50 to 60% have a normal TSH and still they have elevated thyroid hormone levels. Okay, so we can go on to the next slide.
So we went on to further evaluation of the proband as well as the daughter. The SHBG levels were within normal limit for both the proband as well as the daughter. The MRI pituitary was normal for the proband. Pituitary hormone profile was normal. TPO antibody was negative in both, but anti-TG antibody was positive in both of them, with the proband had a level more than 1000, and UC neck in the index case was suggestive of thyroiditis.
Okay, so please pause for a moment. SHBG, we have seen that in face of elevated thyroid hormone levels, SHBG is normal. So that is pointing towards a resistance at the level of thyroid receptor beta, which is present in the liver. Other thing is, because she has hypothyroidism, we are investigating for autoimmunity. That's the most common cause of autoimmune thyroid disease. So do you think the anti-TG antibodies that are present in this case and thyroid autoimmunity in general, is it coincidental or there is some association? Dr. Sharath, you would have read it. You can answer it better.
Yes, sir. There are studies which points out that they are very high likely, around 2.6 times high likely to have a autoimmune thyroid antibody positivity in case of. There has been a study previously by Barak et al., if I remember correctly, which showed that there was a comparison study which compared around 200 individuals against 92 relatives who had TRH beta negativity, and it showed that they had around 2.3 times increased risk of developing autoantibodies to both TPO antibody or antithyroglobulin antibodies. The reason, two probable reasons has been put forward. One is the very high level of thyroxine level that is remaining in the body, stimulating for antibody production. Second is the chronic stimulation of the thyroid gland itself, resulting in an inflammatory state within the thyroid gland.
Graves' disease, hyperthyroidism itself may be an immune stimulator, and euthyroidism, induction of euthyroidism may be modulating the disease activity. It's been postulated that high thyroid hormone levels can be immune stimulatory, and the chronic TSH elevation may lead to a state of pro-inflammation, which causes thyroid autoimmunity. But these are only postulations. We have some association data that clearly shows that there is an increased risk of thyroid autoimmunity in the affected members. Okay, so go ahead.
So so far we have an absence. We have the case can be refreshed from so far workup. There is absence of clinical thyrotoxicosis. There is a positive family history, normal MRI, normal SHBG levels with a resistance thyroid hormone beta with a coexisting autoimmune hypothyroidism is the likely possibility at this point. So we went on with the T3 suppression test. This was the T3 suppression test algorithm that we followed. Several algorithm has been put forward, but the most commonly this was for Werner and Ingbar, where they mentioned the initial a gradual escalation of T3 doses. Initial day 50 mcg for the initial 3 days, given as 25 mcg BD, followed by 100 mcg for the next 3 days, that is given as 50 mcg BD. And third dose, some say 75, some say 100 microgram BD, that is up to 200 microgram can be given for the next 3 days. With this patient should be another algorithm that has been forward to 100 microgram per day for the 10 days has also been put forward, like 40 20 40 different algorithms has been put forward, but the basic concept is to give very high doses of T3 and see the response of different axes. That is, patient should be in hospital, her weight should be monitored, calorie intake should be the same, and other vital should be monitored, especially pulse rate, which can go up, may require adding of beta blockers during the test if it goes above 100. And at each escalation steps, that is day 3, day 6, and day 9, we can do the other markers. One that we can do as part of the test is for a suppressed, after the suppression dose, we can give a TRH stimulation, which is unfortunately we didn't have availability of TRH, but if given, we can see this graph and discuss. This is a normal individual who will show if T3 suppression is given. This is without T3 suppression. So with T3 suppression, the response to the TRH stimulation gets attenuated, and by around 100 mcg dose, it's almost nil. By 100, 200, it's almost no response to TRH will be observed. But in case of resistant thyroid hormone, the response is still retained despite getting a T3 at suppressive doses. And other surrogate markers can also be, other biochemical markers can be used. As we all know that thyroid hormone will stimulate the production of SHBG as well as ferritin. So this is in a normal individual where the ferritin will go up, the SHBG will go up as the T3 dose increases. But in case of a resistant thyroid hormone, we can see that the SHBG response will be blunted, and next will be that even the ferritin may show even a paradoxical response. Similarly, usually cholesterol and creatine kinase level decreases with the exposure to thyroid hormone, as seen in other cases of hyperthyroidism as well. But this response will also be blunted in case of resistance to thyroid hormone. Exact terms are not defined, but the trend will be seen like this. And most important will be to assess the response of TSH, which how suppressible it will be following the T3 suppression test. So this was our patient where the day 3, day 6, and day 9 changes has been noted, and the sleeping heart rate went from 79 to 97. So,
You can be a bit quick because we are running out of time.
oh.
Yeah.
So the most important part in this was that a TSH that was demonstrated that from 12.8 it got suppressed to minus 2.16, which was clearly suggesting the diagnosis of resistant thyroid hormone beta. This was the changes associated with other biochemical markers that we have already mentioned.
So just a point here that the initial slide that Sharad showed, so T3 followed by TRH is very similar to LDTST CRH test that we use in Cushing's. So we can look at it that way. Another thing is that we use T3 and not T4 because T3 has a shorter onset of action and shorter duration of action. So that test can be finished in a finite period of time. And if patient is having normal response to thyroid hormone, they don't develop untoward side effects for a prolonged period of time. And another thing is that T3 tends to bypass the metabolism and transporter defects that can be seen with T4. And that's why we use T3 preferentially over T4. Okay, Sharad.
So this was the overall summary that points we have already discussed, that overall with high TH and suppressed TSH and in background of decreased thyroid reserve, familial segregation was demonstrated with normal biochemical markers like SHBG, normal MRI, and a T3 suppression test showing partial TH suppression, overall suggesting. And there is history of a miscarriage in first pregnancy, which is also important in case of a resistance to thyroid hormone.
What does the history of miscarriage hold importance for?
So the it has been studies has shown that sir, question was to me or
Yes, to you only.
yes, sir. The studies have showed that there is an increased risk of first of all there is an increased risk of miscarriage associated with RTH beta itself. There is around 2 to 3 times increased risk of miscarriage, as well as there has been demonstrated low fetal birth weight and then post-delivery prolonged suppression of TSH has been demonstrated. More importantly, if the fetus is having a theoretically if the fetus is does not having the mutation of resistance to thyroid or RTH mutation, then the T4 that is excess in the mother will be in a way hyperthyroidism for the fetus. If it is the fetus has the mutation, it is in a way protective for the fetus.
Is RTH beta where the mother is affected but the fetus is unaffected, or fetus has wild type TR, is a very good model of isolated fetal hyperthyroidism, something that we have learned in a patient with Graves' disease who had undergone radioiodine ablation in the recent past. So this is another model of isolated fetal hyperthyroidism, and it's been shown that these individuals are at increased risk for miscarriage, and also if they deliver the baby is likely to have lower birth weight and a postnatal TSH suppression compared to those babies who are having an affected phenotype. So this is also very similar to glucokinase MODY or calcium sensing receptor defects that we very well understand in endocrinology. Okay.
The clinical diagnosis was resistant thyroid hormone beta with a coexisting autoimmune hypothyroidism. So we went on with the genetic testing, which was clinical exome sequencing was sent, which demonstrated that there was a single nucleotide variant at exon 8 of TRHB gene, resulting in a missense mutation, replacement of arginine at the 243rd position by glutamine, and it was heterozygous in nature. And more importantly, it was previously reported, the same mutation has been previously reported in case of RTH beta, which was a strong, such a strong indicator that is pathological. Secondly, the same experimental studies has shown a pronounced effect on protein function with respect to the region. And the same different missense at the same location, different missense change has been reported previously. And in general population, the studies has like 1000 genome and genome AD has shown that the same mutation is same variant is usually not seen in general population, as well as it is a reference codon that is conserved across the species, that it is an important codon and has been preserved from the evolutionary perspective. And in silico prediction also showed probable damaging. So the interpretation overall was pathogenic because even the PS1 and PS3 alone will make it pathogenic, and the other two moderate evidence were also there with respect to being rare in general population. And PP1 was that we could demonstrate the familial segregation also. So this is the classification of genetic variant, that is the 5 points.
Okay, so you can skip this slide. I think this can be read.
Yes, sir. This was the Sanger sequencing, which shows that that electropherogram showing heterozygous condition, heterozygous variants in both the mother as well as in the both in the proband as well as in the daughter. It was similar, same heterozygosity mutation variant was demonstrated. So the final diagnosis was resistance to thyroid hormone beta with coexisting autoimmune hypothyroidism. Review of literature.
We will move to the management part because we have less of time.
Okay.
So we can move to the management part. So I think just go back to the previous slide.
Nice.
The last one, the coexistence of hypothyroidism.
Okay.
So I think one of the challenges in this case was that not only RTH beta is present, but there is coexisting hypothyroidism, but the concept remains same, that at any level of TSH, if you see abnormal T4 levels, which does not, which tends to violate the relationship that we see, you should suspect coexisting hypothyroidism or hyperthyroidism. So if you have autoimmune hyperthyroidism, you're treating the patient with antithyroid drugs, TSH normalizes and T3 and T4 remains elevated, which is just the reverse of what we expect in clinical practice. TSH tends to take longer time. Then you should suspect coexisting hyperthyroidism, or when you see very high T4 levels abnormal for the degree of TSH elevation, you should again suspect hypothyroidism. So there are only handful of reports which have been highlighted by Dr. Sharath. Another thing that has been described is TTRI, which goes on to show that at any level of TSH, you expect higher free T4 levels. So if you do a multiplication of TSH with free T4, where free T4 is expressed as percentage upper limit of normal, as you can see in this slide, you can expect that in RTH patients, you expect a high TTRI level as compared to a normal control. So Sharath, you move to the next slide. And we can see that in the TTRI in our patient varied between at any point in time, at every point in time, it should be demonstrated. We should not pick and choose TTRIs. So at every point in time, we can see that it is clearly elevated. Sharath, go on.
So coming to the management, the basic concept is there is no treatment to correct the basic defect. Most cases are partial tissue resistance. Concomitant hypothyroidism is one condition which warrants treatment. And in childhood, they can present with conditions like ADHD, bone mature growth, short stature, or delayed bone age, or hyperactivity. All these can be indications for treatment. Or the sorry.
Yeah.
All these can be indications for treatment, and the guidance for treatment can also be assessed from outcome from other family members. So our patient definitely had an indication that is she was having a primary hypothyroidism along with it, but were to target the treatment starting on levothyroxine, it was probably the baseline index thyroid function test we had, which was actually the normalcy for her with response to which was in a way compensation for her tissue level resistance, that T4 of around 18.6 and TSH of 4.3 would have been the normal target for the given patient, since comparing her index thyroid function test.
There are very few indications of treating RTH. One of them is highlighted in this case. If there is coexisting hypothyroidism, we would want to treat the patient to a T4 levels that maintains normal TSH. We don't have to think that high T4 levels are there, because this is the T4 that is setting up the axis in a perfect manner for this patient. Other indications that have been described are large goiters, attention deficit hyperactivity disorders, or also brain fog, for which T3 treatment has been described occasionally. One important aspect that I wanted to discuss was that if you have an affected mother with unaffected fetus, which is proven through chorionic villus sampling or amniocentesis, you can start antithyroid drug therapy provided free T4 levels are more than 150% upper limit of normal. That's when you initiate the amniocentesis and genetic testing part. And then you can, if the wild type TR beta is being detected in the fetus, then you can start the treatment targeting a free T4 level of less than 120% of the upper limit of normal. That's been shown in very small studies. These are all observational, small scale, 15-20 patient studies. That's been shown that it tends to normalize birth weight and reduces the postnatal TSH suppression. Yeah, go ahead.
So in a patient with daughter who had symptoms of palpitation was treated with propranolol for the relief of palpitation. Other agents that have been tried, as Sarah has already mentioned, T3 has been high dose, T3 single dose has been tried for goiter and ADHD. Triac has also been, due to its preferential central action more than peripheral action, is another agent that has been, analog agent that has been tried. And future challenges with respect to our case, one is the proband who requires levothyroxine titration to achieve normal TSH and a baseline, what was the baseline T4 that for her that is to be achieved. daughter, especially follow up for evaluation into hypothyroid state since she already has a positive autoimmune antibody. Second is her pregnancy implication. As we already discussed, she is at risk of 3 to 4-fold increased risk of miscarriage is there in the unaffected fetus. So, and the evaluation of the sister, which needs further evaluation. She needs close follow-up and levothyroxine titration and further genetic confirmation. And her children are also to be need biochemical screening, and the other family members who has been missed out also needs screening. So the overall learning points, that is, one is atypical thyroid function always requires careful evaluation and interpretation with respect to the clinical context. As already been discussed in detail, that drugs, autoantibodies, and lab interference should be excluded first. RTH beta, which is actually a TH response, is inappropriate. So,
Yes, please go ahead.
I see. Is actually not. And second, on evaluation, the important one is the tissue biomarkers that we have: familial segregation, T3 suppression test, which we have discussed in detail, molecular testing, and pituitary imaging. Coexistence of thyroid dysfunction can always make it very difficult to a challenging diagnosis, but as we are seeing, there are different. So
Yes. So thank you, Dr. Sharath. I think we had a good discussion, very well presented and very well discussed. Apologies, Dr. Sandeep, we have overshooted time in lieu of some questions and some discussion, but I hope you would afford us that liberty. Thank you so much.
So thanks a lot. It was a true masterclass, and in fact, we could continue more. And it will be one of the most memorable case capsule ever discussed. And thanks a lot, sir. And
thank you so much.
And thank you, Dr. Sharath, for beautiful presentation. And thank you to all the panelists. And it was a great interaction, great learning, and for all of us. And with this, now we come to the one of the interesting part, and that is a quiz for the case capsule. And let me share my screen. So I believe I'm okay. So I believe my presentation is visible to you. You can see the first slide of the mentee.com.
Yes, Dr. Sandeep.
Thank you. Okay. So welcome everyone. So we come to the one of the most interesting part of the case capsule, that is a case quiz. And all of you are aware by now that we conduct it on www.mentee.com. And it is just a repetition for you that you can access this quiz simply by scanning this QR code, and or you can access this quiz by simply going to www.mentee.com and enter this code. And we'll be here for around 10 to 20 seconds on this slide so that all of you can scan this QR code. But don't worry if you are not able to enter the quiz. This code number would be displayed in all the subsequent slides. So if you happen to log out because of whatever reason, you can again re-enter the quiz by simply entering this code, which would be displayed in the all the slides of the quiz. So this is one of the most important information and exciting news for today, that now from today's session, and we have a master class on RTH beta, how the this is a good occasion. Now we have made the cash prizes for the top 3 winners. Earlier we were having only for the top 1 only, so we'll be giving the cash prizes to top 3 winners from this chapter onwards. And the first prize is 10,000 rupees, second prize is 7,500 rupees, third prize is 5,000 rupees. So that is a good news. So the motivation to all the DM and DNB students here. And let me clarify the rules. That the first rule is always that decision of the quiz master would be final, and you need to have 2 smart screen devices. This is known to all of you, and one is the screen on which you are seeing this quiz, and another is like you can have your mobile phone as a smart screen on which you would be attempting the quiz answers. And remember, we are not looking for only the correct answers, we are looking for the fastest correct answer. So even if you make all the questions correct, and if you were late, then you may not win the prize. So remember that, because this platform is also assessing how fast you were while making the correct answers. So we wait for more 10 seconds and we see more and more people are joining. So I think in next 10 to 15 seconds, we would be good to go. Good to go with the quiz. And so don't worry, even if you log out by mistake during the process of the quiz, the QR code which is displayed on the top of the slide would be displayed on all the subsequent the quiz slides. So I think now we are good to go. Most of the students have joined. And okay, so with this now let us start with the question number 1. And yes, now we are good to go. Most of the participants, so the students have joined the quiz, and now we start with the question number 1 of today's quiz. So here is a question number 1 on your screen. And the question says the major thyroid hormone binding protein in the cerebrospinal fluid, CSF, is albumin, transthyretin, or thyroxine binding globulin. I think it is fairly simple, and I expect most of you would be able to answer that. So with that, we end the time. Okay, so the correct answer was transthyretin, and the few of you could not answer, but yes, most of you could answer it correctly. So this transthyretin is a thyroid hormone binding protein in the CSF. And let's check a quiz leaderboard. It would be intermittently after a few slides I would be doing this. So this is just to have an understanding. Don't worry if you're lagging in this answer. So still you have a lot of options and a lot of opportunities to catch up. But yes, at this juncture, Dr. Isha, Dr. Nupur, Dr. Nanda, and Soumya, Nikhil, etc. These are the leading. So don't worry, people who are lagging, you have a lot of opportunities in subsequent questions. So the answer to this was directly from the Williams. In fact, the most of our quizzes we stick to the Williams only, and this is you can refer to this. Transthyretin is expressed in the choroid plexus, and it is a major thyroid hormone binding protein in the CSF. So that is important thing. And other the binding proteins you are aware, we discuss about it. Albumin we discuss about, globulin also, TBG also. So with this we go to the question number 2. And the question number 2 is here on your screen. And remember, it is the fastest. Time is very important while you are making the correct answer. So it is a Allen-Herndon-Dudley syndrome. It's an X-linked condition which results from the defect in the transporter protein, thyroid transporter protein, and it is coded by which gene? It was discussed in the case presentation by the Dr. Alpesh Goel. And so you have option OP1C1, MCT10, MCT8 gene. So which one of this is the correct answer? Which one of these gene is involved? And as expected, most of you could answer it correctly. It is MCT8 gene. But sadly, few of you could not do that. And again, this is directly coming from your Williams. And here it is seen that Allen-Herndon-Dudley syndrome is an X-linked condition. We discuss it that only the males, all the males would be affected and the females would be the carrier. It is characterized by the severe mental retardation, dysarthria, athetoid movements, muscle hypoplasia, and spastic paraplegia subsequently. And it is associated with elevated serum T3. And that is why in this atypical thyroid hormone case, this was also one of the point of discussion during the differential diagnosis. And then with this, we come to the question number 3. And wish you all the best. And don't worry if you were not able to make the answers correctly. You have a lot of option to go because we have not even through 20 to 30% of the today's quiz. And the question number is 3 is here on the screen, which is a wrong match for the iodine content of the various pharmaceuticals. So it is a paired. We've written what is the pharmaceutical agent and how much is iodine content. So which one is the wrong? So such SSKI 38 milligram per drop, Lugol 6 milligram per drop, Amiodarone 200 mg tablet containing 25 milligram of iodine, or iodized salt 1 part Ki at 10,000 NaCl as a ratio of 760 microgram per 10 gram. So which is the wrong match of the iodine content in the pharmaceutical? So correct answer was amiodarone. It was pretty simple. All of you are aware that iodine content in then amiodarone is about 35 to 37%. 100 milligram of tablet would contain about 37 milligram of iodine. This is pretty high, and we knew if your recommended dietary allowance is about 150, so it is pretty, and that is how it leads to the various thyroid dysfunction. And it is very interesting to read in detail about what are the various mechanism and what are the various thyroid dysfunction which can happen with the amiodarone. And in clinical practice also, we frequently see the patients who present with such picture. And we can have a quick check at a leaderboard. And so we have Dr. Somya, Dr. Nupur, Dr. Nikhil, Dr. Isha, Dr. Raj Kamal. They are doing it, and in fact, there's a close competition with others also, and we can see the points 2860, and we have a lot of people in the 2800. So you have a lot of opportunities to catch up. Wish you all the best. You have a lot of questions to come still. And please remember that it is speed is very important while you have to make the correct answers. And this is again the table from your Williams. So it's very important to refer to all the tables and flow charts from the Williams, and it gives you the iodine content of the various pharmaceutical agents. So with this, we go to question number 4, and the question number 4 is here on your screen. So it says that when tested in bioassays, the potency of normal SCG to TSH receptor is, in normal situation, what is the potency of SCG when combining to the TSH receptor? It is 1:1 as potent as TSH, 1:10 as potent as TSH, 1/100 as potent as TSH, or 1/1000 as potent as TSH. So maybe a little difficult for people to understand it, and we all are aware that SCG can bind to the TSH receptor, and it is an important thing when we see the patients in the first or second trimester of the pregnancy, and it has been seen that the potency in the normal physiology is about 100. As potent as TSH means its capacity to bind to the TSH receptors. However, in a certain condition like familial, the gestational thyrotoxicosis condition, it may be the potency of the SCG to bind to TSH receptor may be abnormally high, but in the normal conditions, it is about 100 that of a TSH. And then we go to the question number 5. We are almost halfway through, so please wake up and try to answer the correct answer at the fastest speed. And the question is, the daily levothyroxine requirement in the newborn is a pretty simple question, and I'm sure all of you would be able to answer it correctly. So it is 10 microgram per kg, 5 microgram per kg, 1 microgram per kg, 1.6 microgram per kg. So when you're treating with a newborn with the levothyroxine, how much dose would you be giving? Okay, so very good. All of you could answer it correctly. And we know that the dose in the newborn is higher, that is 10 microgram per kg. So this brings us to the next question. And the next question is based on this graph. So basically, this is a graph which is showing, according to, this is showing the graphic representation of various thyroid function, and it represent the non-thyroidal illness. Is a graph. So how the thyroid functions are there in the sick euthyroid or non-thyroid illness syndrome. So question which you would be answering on the basis of this graph is, what is the thyroid hormone function profile when the patient is sickest? So that is the question for you, and the question would be there in your next slide once we enter. So keep that graph in mind. And we were talking about non-thyroidal illness or sick euthyroid. And the question is, what would be, out of the options given, which options would be the correct, which represent the pattern of the thyroid function when the patient is sickest? So either it is low free T3, low free T4 with low TSH, low free T3, low normal free T4, TSH low, or low free T3, low free T4, or TSH normal. So which one is the correct when the patient is the sickest and having a non-thyroidal illness? So, I'm surprised that a few of you could not answer it correctly. So the answer is the option number one, that low free T3, low free T4, and TSH low. So generally, when the patient becomes sick, and you should be reading about it, that in non-thyroidal illness, when it starts, the pattern is a low T3 syndrome. So it is presented. You see the thyroid function in the form of low free T3, free T4 is normal, and TSH is normal. However, when the patient becomes sick or he is the sickest, the thyroid functions represent in the form of low free T4 and low free T3, low free T4, and even the TSH becomes low, and it is also one of the prognostic indication, means it denotes the poor prognosis in the patient whenever it is present. So with this, and this is again the table which comes from Williams, and so it reinforces why it is very important to go through the tables, charts, and in fact they give us a lot of information, even pathophysiological mechanism, even simply by going through the charts and flow chart tables and flow charts of Williams. So with this, we come to the question number 7 of today's quiz, and the question number 7 is here on your screen. And it says the means Lerman scratch in thyrotoxicosis. What is it? So it's a pretty simple one. It is loud S1 first heart sound. It is a mitral valve prolapse related, the sound, or it is scratching systolic sound along the left sternal border, which represent something like pleuropericardial rub. So basically, all these three options are seen when the patient is thyrotoxic, and the mitral valve prolapse is also commonly seen. We have a loud S1, but this mean Lerman scratch is because of the scratching sound, which is seen in the left sternal border, which represents a pleuropericardial kind of rub. So this was the correct answer, and most of you could make it correct. So with this, we go to question number 8, and the question number 8 is here on your screen. And it says that smoking is well established risk factor for Graves' disease. That is known to us. An odd ratio for Graves' hyperthyroidism in smoking is 3.3. That is known to us. So what about alcohol consumption? How alcohol is related to the risk of the Graves' disease? It causes a significant reduction in the risk, or it causes a significant increase in the risk of the Graves' hyperthyroidism. The correct answer is that I'm happy that most of you could make it correct. And the answer is that there is at least we have a robust data now that the moderate consumption of the alcohol may be associated with a considerable risk reduction in the Graves' hyperthyroidism. So we can have a quick check at leaderboard, because we are now almost 80% through with the quiz, and we have now the topmost student with 50 points. Dr. Jab is there. Dr. Nupur is there with 75-23, 74-58 point with Dr. Isha. Wish you all the best. You have still a lot of opportunities to catch up, and please focus on your speed while answering the correct answer. And with this, we go to the next question. And the question number 9 is here on your screen. And the question says, trial in Graves' orbitopathy is what? It deals with what? So whether rituximab in Graves' orbitopathy, it deals with atorvastatin added to glucocorticoid in Graves' orbitopathy, or it is a study which have studied the teprotumumab in the Graves' orbitopathy. So the Sledger trial basically is very interesting, and it is basically a sensitization for all of you to go back and read. It is deals with when atorvastatin is added to the intravenous glucocorticoid, it is associated with significant incidence of the reduction in the incidence of Graves' orbitopathy. So it's very the new thing in the armamentarium, which is in the management of the Graves' orbitopathy. And with this, we come to the question number 10 of the quiz, and the question number 10 says, resmetirom is a drug which is FDA approved for the MFLD. What is the mechanism of action of this drug? Very simple. We discussed this, and this is the first drug which has been approved for the metabolic associated fatty liver disease. What is the mechanism of action of this drug? It is a thyroid receptor beta agonist, alpha agonist, anti-TNF alpha agent. So it is thyroid receptor beta agonist which act at the liver level, and this is very important, and drug which have proven benefit in the metabolic associated fatty liver disease. And this is also a point for us to get ignited and read about how the thyroid hormones have effects at various tissue levels, and probably also just read about various thyromimetics in the and how the historical endocrinology have evaluated the thyromimetics in various diseases. And with this, we come to the last question of today's quiz. And the question is here on your screen. And wish you all the best, people who are in close fight. This is opportunity to catch up. And the question is, the incidence of hypothyroidism with the use of immune checkpoint inhibitors is highest with which option? CTLA4 inhibitors, ipilimumab, or PD-1 inhibitors. So all of them can cause a thyroid dysfunction. In fact, Dr. Alpesh Goel has beautifully, have taken, class on this also in the Endocrine Society forum earlier. And these drugs can cause various endocrine disorders. So highest we've seen with PD-1 inhibitors, and it's been seen that the incidence can be as high as about 8 to 20%. And it is with CTLA4 inhibitors, the incidence is about 3%, and with ipilimumab about 4 to 5% incidence of hypothyroidism can be seen. So with this, we have finished with all the questions of the quiz, and let's check the quiz leaderboard. And as we discussed, so we have a cash prize for two top 3 winners, and the leaderboard is settling down. And so we have a winner, Dr. Nupur. Congratulations to you. Dr. Nupur has won with 10,247 points. Dr. Jab is second with 9,469 points. And we have Dr. Raveen Thomas, who is third with 9,452 points. Wish you all the best. Congratulations to you, and you did really well. And even the other people who were there, and it is just, we can only choose the 3 winners, but you really performed well, and wish you all the best for the future quizzes. And you contact me for your prizes. And all of you 3 winners would be the panelists for the next ESI case capsule, which we would be having in the for the last Wednesday of the next month. And with this, we come to end of this case capsule. Thank you for everyone, and it will. And I would be informing you what would be the topics and what would be the case for the next month's case capsule. Thank you, everyone.